Well, hello everyone. I'm Trevor Duke, a pediatrician, and this is another teaching session about the Pocketbook of Hospital Care for Children, which is a set of guidelines that the World Health Organization published first in 2005, and then the second edition was published in 2013. And there are, in addition to the guidelines, there are teaching modules that teach healthcare workers how to use the guidelines, how to use the World Health Organization guidelines, the WHO guidelines in everyday clinical practice. And this is a teaching module about chapter 6 in the book, which is on fever. Now, it's a long chapter and there are many different causes of fever, of course, but we'll just go through one case. It's a case-based scenario where we'll go through a case and try to use the book to manage a child with fever. I'll just share my slides and then we'll make a start. As I said, the World Health Organization published this book in 2005. Before that, there was a book that of guidelines that looked after the child with severe infection or severe malnutrition. And this book was published in 2005 to encompass more than just infections and malnutrition, because at a district level hospital, healthcare workers see many different conditions, uh, and um, and they look after children with a variety of different problems. This chapter's on fever, and it covers all the different types of causes of fever, in the common causes of fever in children. We'll start with the case first, and then we'll go through it and see if we can explore the different causes of fever based on the structure that WHO suggests one uses. So this is a case of Johnny, this little boy, a 6-month-old boy. He was brought to the hospital with a 3-day history of fever and lethargy, and he'd not been feeding for the last two days, not feeding well for the last 2 days. And you can see him there. He looks quite sleepy, and he could be just sleeping, but he looks sleepy, and he was difficult to rouse um, at triage. Now, whenever we see a child who may be seriously ill, we have to think about the stages of management of any sick child. And WHO has a framework for the management of any sick child in a hospital, and these are the following. Triage being the first one. So triage is a form of sorting out patients who have emergency signs or priority signs or neither, and deciding which order these patients need to be seen in. Second is emergency treatment, and if you find emergency signs, then you stop the triage and you give the emergency treatment that's required. Third is history, taking history and doing an examination, and that will inform the diagnosis. You can come up then with a main diagnosis and a differential diagnosis. You may require some laboratory investigations to be done to help inform your diagnosis, or to help support or your diagnosis, or exclude other conditions, or look for complications of the underlying disease. That's another part of it. And then giving treatment for the main and other diagnoses that you've come up with, and then providing supportive care and monitoring the child, and then discharge planning and follow-up. All of these stages are important in the care of any seriously ill child, as this child is. So at triage, again, you can get quite good at doing triage within a minute or two of seeing any child. You take a brief history, as we learnt about Johnny, the little baby I presented before. Take a brief history of the presenting problem. So 3 days of fever, being unwell, and 2 days of not feeding well. Take the temperature of the child. That's important. It can help differentiate febrile illness from non-febrile illness. For example, weigh the child, because that's important if you have to give emergency drugs or give medications of any sort. And then simply pay attention to the airway, breathing, circulation, and conscious state or disability. First of all, listen for stridor or obstructed breathing. You can see the signs of obstructed breathing, or you can listen for stridor. Look for cyanosis and signs of respiratory distress. So just by standing back and looking at the child, you can look for a chest indrawing or tracheal tug or grunting respirations or head nodding. They're all signs of respiratory distress. And if you can, check the oxygen saturation if the child's got any signs at all of respiratory distress or any other emergency signs. You should, for the circulation, again, you can get quite good at this very quickly by feeling the skin temperature of the hands and the feet. And then if the hands and the feet feel cold, feel how high the the cold temperature goes up the hands and the feet. Feel the peripheral pulses, so either the radial pulse or the in the feet, the dorsalis pedis or posterior tibial pulse. It's good to get used to feeling the pulses and feeling the hands and the feet of children of all different ages, because the pulses of a newborn, a neonate, are different to an older infant, are different to a child, and different to an adolescent. So get used to feeling what's normal, and then you'll be good at feeling, identifying what's abnormal. And then you check the capillary refill time when you're feeling the hands and the feet. So three things: the temperature, the peripheral pulses, and the capillary refill time. And if you've got a child who's got warm hands and feet, has got strong volume pulses, a capillary refill time that's less than 2 seconds or less, then they don't have shock. Whereas if you've got a child who's got cold hands and feet going up to the elbows with uh, poor volume pulses or pulses that are difficult to feel and a prolonged capillary refill time, then the child may have shock. And then you assess the child for lethargy and level of interaction. And that's, of course, all age appropriate, because the interaction you get from an older child is different from that of an infant. But you need to assess the child for lethargy. And you can do that in a formal way, like doing a AVPU score, which is the child alert, or do they respond to verbal stimuli, or do they respond to painful stimuli only, or are they unresponsive? You can do it that way, or you can stimulate the child and see if they rouse to voice, or if they're alert, or if they're unresponsive. So making that assessment will help you identify emergency signs. And again, if you've got a child's got emergency signs, then you need to do something about it, generally speaking. So this was Johnny's vital signs. He had a temperature of 39.7, so a very high temperature, the upper limit of normal being about 37 and a half. And if you've got a child's got a temperature above 38, 38 and above, then clearly they have a fever, and Johnny's temperature was 39.7. Pulse rate being 185. Again, that's out of keeping with, that's way outside the normal range, isn't it? Normal being up to about 150, maybe 160 in some cases, but 185 is very high. Respiratory rate of 48. Again, that's a bit high, higher than normal, and it may be because of his temperature. A saturation of 97, oxygen saturation of 97, no respiratory distress. His capillary refill time was 3 seconds, so that's a bit long, but he had warm hands and feet and bounding pulses. So he's not in shock. He might, but he's got a high fever and tachycardia and mild tachypnea. And you can see him there. You can also perhaps see that he looks like he's got a fine rash on his trunk, a fine red rash on his trunk, and on his face, just a little bit of a rash as well. So in terms of at triage, you need to decide, does the child have any emergency signs, or whether they have any priority signs. And Johnny didn't have obstructed breathing or severe respiratory distress. He had mild respiratory distress. He had no central cyanosis. He didn't have signs of shock. He only had one sign, a bit prolonged capillary refill, but not all signs of shock. He wasn't in coma. He was lethargic, but not in coma. He hadn't had convulsions, and he didn't have signs of severe dehydration. He still had warm hands and feet, and his capillary refill was okay. So he doesn't have emergency signs. So we don't need to necessarily stop everything we're doing and rush in and give him oxygen or intravenous fluids or anticonvulsants or anything like that. But does it? The question is, in a triage situation, is he okay to just wait until the end of the line, or does he have any priority signs that would mean that he should be seen promptly? Not necessarily having emergency treatment, but to be seen promptly. And I think these are the priority signs. If you look up the Hospital Care for Children book on page 6, you'll see the priority signs. And these are the priority signs. So when you go through it, he certainly had a temperature, a very high temperature, and he was lethargic. So again, you only need one priority sign, and a child should be elevated in the queue. If there's a long queue of patients, then they should not be put right at the back to be waiting until all the other patients have been seen. So he should be seen as a priority within a short space of time, because he's obviously quite sick with a high fever like he had and being lethargic like he was. Does he need any emergency treatment? No, no, he doesn't really need any emergency treatment. His airway's okay, his breathing's okay, his circulation, well, he's not in shock, so he doesn't need large volumes of intravenous fluid necessarily, although he had not been drinking for a couple of days, so he might need some additional fluids, but not boluses of intravenous fluid, which might only make him worse. He was lethargic but not convulsing and not in coma, so therefore he hasn't got that emergency sign. He probably is going to need an intravenous cannula for blood tests and antibiotics, and that would be a first thing you might do as far as emergency treatment goes. You'd probably get a blood culture if you can, other blood tests, and you'd think that probably with a temperature of 39.7, he might is likely to need antibiotics. And you might, because he's so lethargic, you would want to check his blood sugar. So you could do that when you put an intravenous cannula in. And he's had 3 days of not feeding well, or 2 days of not feeding well. So it's likely that possible he might be hypoglycemic as a cause of his lethargy. So now, after you've done triage and ruled out that he needs any emergency treatment, classified him as having priority signs, you need to take a history. And this is a slightly more expansive history. We knew that he's 6 months old. He was brought to hospital with a 3-day history of fever, lethargy, and not feeding. He'd vomited several times each day, and his mother said that he felt very hot to touch throughout. He'd had no diarrhea. He was a previously well baby, a term baby born in hospital. He's got two other siblings, aged 3 and 5 years. They're well. All the people in his family are well. He's got no past history that his parents knew about. His immunizations are up to date, and he was still breastfeeding. He'd started solids 1 month ago and started on some banana and papaya, but otherwise was a breastfed baby. So after we've done triage, emergency treatment if needed, prioritized him, taken a history and an examination. So he was lying, you could see, with his eyes closed. He wasn't rousable to voice, but he was rousable on handling. His vital signs we talked about before. His temperature was very high, temperature of 39.7, the pulse rate of 185, respiratory rate of 48, and you know what his circulation was like. Mildly impaired, but not very impaired, not in shock. His weight was 6.9 kilos for a 6-month-old baby. That's pretty good. You could check the weight for age chart in the Pocketbook of Hospital Care for Children. There's a weight for age chart, and there's also a weight for length chart. If you wanted to measure his length, you could look at his weight for length. But he looked like a well-nourished 6-month-old baby, didn't he, to look at the picture of him. He had no chest indrawing and good air entry both sides. So even though he's got mild tachypnea, it's unlikely he's got, a serious respiratory infection as a cause of his high fever. He was tachycardic, we knew about that, and he's got a soft systolic murmur. When you listen over his chest, he's got a soft systolic murmur, and that could be because of fever, can be because of anemia. Of course, it could be because he's got congenital heart disease, but it could just be related to his fever. He had a soft abdomen, although he was a little bit tender to palpate his abdomen, and his liver was palpable 2 centimeters below the right costal margin. That's just above the upper limit of normal. He did seem to be a bit tender when his abdomen was palpated. He was lethargic, but not having any signs of meningitis. No neck stiffness. His fontanelle was normal, and he looked a bit dry, and he had no signs of oral thrush. Dry mouth. His eyes were clear without discharge, and he had this. You saw this fine red rash on his chest and abdomen, arms, and his face. A very, very fine red rash. So now we've done triage and emergency treatment or prioritization, and we've taken a history, done an examination. So we need to now think through the possible causes of the illness. And in reality, when you're seeing a child at triage, when you're taking history and doing an examination, this is the thought process that you should be working through all the time. You should be thinking, well, what's the most likely diagnosis, and what other pieces of history or pieces or signs on examination do we need to rule in or rule out a given diagnosis? So I always try to think of the three most likely diagnoses and then use that clinical process of history and examination to rule in or rule out or make more likely or make less likely certain diagnoses. And then you can order the diagnoses in a list. So sometimes we call other possible diagnoses a differential diagnosis. So those three diagnoses could be a differential diagnosis. And sometimes you have a child who's got other secondary diagnoses like complications or something else. They might have fever and anemia or or pneumonia and diarrhea. And they're in a way they can be comorbidities, or they might have a febrile illness and underlying malnutrition or something like that. Then they can be comorbidities. The World Health Organization, the WHO Pocketbook of Hospital Care for Children, divides fever up into four different categories. And there's some overlap between the four categories, but generally speaking, it's useful to think of children a bit like this. So fever without any localizing signs, if they've got a swollen mastoid or they've got an abscess, then that's a localizing sign. Or if they've got a swollen joint or a painful joint in an older child, or they've got a swollen red eye, then they are clearly localizing signs. Johnny didn't, he seemed systemically unwell, fever, lethargy, a faint rash on his body, but no clear localizing signs, nothing that would localize an infection to a particular place. There's fever with localizing signs. I mentioned most of those or many of those. Meningitis is another type of fever with localizing signs, but this boy didn't seem to have any of those features. Fever with rash is another possibility, another possible like way of thinking about this child, because he did have a faint red rash on his body, and then there's fever lasting longer than 7 days, and we know that Johnny's fever was only 3 days, so it doesn't fall into that category. So we could think about fever without localizing signs and maybe fever with rash in thinking about what this child's most likely diagnosis is. And in the WHO Pocketbook of Hospital Care for Children, there are tables that list the diagnoses, and then they list the signs or symptoms that would be in favor of such a diagnosis and make it more likely. So you can read them and learn that yourself. So when you are taking history and doing an examination, you can rule in or rule out different diagnoses or prioritize a diagnosis. That's what you're trying to do. This is the part of the table for fever without localizing signs. I said that Johnny had a general systemic illness, wasn't it? And so there's certain sorts of infections that produce fever without clear localizing signs would be malaria, if a child's from an endemic area, and it's possible this child came from a malarious area. Septicemia in general, a generalized sepsis-like illness, they sometimes will have some features that suggest sepsis, usually severe circulatory impairment, isn't it? Typhoid fever can be a fever without localizing signs, although sometimes there's a bit more localization to the abdomen, or they present in shock. And then urinary tract infection, certainly in an older child, they can have a localizing sign like symptom, like they have dysuria, painful urination, or their frequency of urination. But in an infant, often there's no localizing signs at all. They won't have any signs but fever, and that would be common. Older children can tell you if they've got a UTI because they can complain of pain, intense pain, usually when they're passing urine. Usually, not always, but a young infant can't complain of that. They're just often lethargic, irritable. Then they become lethargic as they become more infected, and they'll just have a high fever. And then fever associated with HIV infection. Well, again, you need to look in the book for signs of HIV infection, but does not seem very likely in this child, does it? This is an acute fever. This is more likely to be something else. So this is not all the differential diagnosis of fever without localizing signs, but they're some of the important ones. Of course, viral infections are, a very common cause of fever without localizing signs. Sometimes there are localizing signs in the upper airway with coryza and cough, or respiratory infection, but not always. And sometimes with some viruses, influenza, for example, it can be just a high fever without any localizing signs. So virus infections come into this as well. But I guess the WHO Pocketbook of Hospital Care for Children is teaching people to identify the most serious and dangerous conditions, and those that require specific treatment. All of these, malaria, septicemia, typhoid, urinary tract infection, they all require specific sort of treatment. So, of course, virus infections are probably the most common cause of fever, but usually they get better by themselves. Usually, although they can be serious, they usually get better by themselves. And then there's the table in the WHO Pocketbook of Hospital Care for Children on fever with rash. Johnny's rash was a very, very faint, you saw it, a very, very faint, particular tiny red dot rash. I mean, it didn't really look like measles, but if you again would go through these clinical signs that are in favor or not in favor, so always with measles, you get a cough, coryza, usually conjunctivitis, cough, coryza, conjunctivitis. They're the cardinal features of measles. So it doesn't seem very likely that Johnny has that because he didn't have any of those features. Virus infections like a generalized viral infection will often cause influenza, or enterovirus will often cause a red rash. And it's possible that he could have some of that. Usually you have some other feature like a respiratory infection or like diarrhea, and there was nothing like that. There was vomiting only and high fever. Other infections with fever and rash you could think about, such as dengue, for example. Sometimes in dengue there'll be a fine petechial rash on the body because the platelet count will be low, and that would be worth thinking about in this child. Although, of course, with dengue, it's usually not the first infection that causes, a serious infection. Is it? The first infection will just cause a fever, and it's usually after the second infection with dengue. So older children typically, but nonetheless worth thinking about if it was a dengue area, or just similarly with malaria. You might want to do some investigations, given that this is fever without localizing signs, or fever with a mild rash. Checking the blood sugar first because he's been not feeding for a few days. Doing a full blood examination could be useful. You might find something that gives you a clue as to what the infection is. Taking a blood culture, he's systemically unwell, he's got a very high fever. You would want to take a blood culture if you can. And because in infants and young children, there are some infections that you can't find the cause of unless you specifically look for those infections. So you have to look in his ears, for example, to make sure he doesn't have otitis media. You have to get a urine microscopy. Otherwise, or a urine test. Otherwise, you won't be able to rule out urinary tract infection in a 6-month-old baby who's got a very high fever. So you'll have to be able to get a urine test, a urine sample, and I'll explain how to do that. If Johnny came from a malarious area, you'd want to do malaria microscopy and a rapid diagnostic test. And he's quite lethargic. And if he had any signs whatsoever of meningitis, then you could do that. I think he was lethargic, but not really with signs of meningitis. But again, a high fever. If you don't find any other cause, then you should rule out meningitis with a lumbar puncture, as long as it's safe to do so. And there's good reason why it might not be safe in this child. This was his full blood count. This is the real full blood count of this child. And you can see, just let's go through it. Well, firstly, his hemoglobin is a bit low, 8.9. And if you see this, then you should think to yourself, well, is there a reason why this could be? Well, he's 6 months old, and that often in babies of 6 months, their hemoglobin's a bit lower. His diet seems to be pretty good. He was breastfed exclusive. Well, he was breastfed up until a month ago exclusively, and now in the last month he's been on some solids, which seems like a normal sort of approach in this sort of child. Sometimes, so not very strong evidence of iron deficiency, unless his mother was also iron deficient. So you might think, let's have a think about that, and then. But sometimes in acute infections with a very high fever, the hemoglobin will drop. So perhaps that's the cause of his mild anemia. Yeah, the concerning thing is his platelet count is very low. The normal platelet count 150 to 400, and his platelet count's only 35. That's very low. And most likely this fine rash, red rash he's got is related to low platelets. And when you see that, you'd be thinking to yourself, well, it could be, you can see that sometimes in viral infections. You can see it sometimes in serious bacterial infections. You can certainly see it in dengue, low platelet count. So you'd be thinking to yourself, well, what could fit in? And when you're doing investigations, it's important to triangulate the information that you've got from the history and the examination and the investigations. Triangulate means putting them all together and seeing what fits and what doesn't fit. And so far, on the full blood count, we know he's got a mild anemia. He's got thrombocytopenia, that's low platelets. He's got a high white cell count, a bit high, isn't it? His total white cell count's a bit high. And mostly what's high is his neutrophil count. And again, that suggests it's a bit more likely that he's got a bacterial infection if his neutrophil count's high. His lymphocyte count's low, which you see sometimes in virus infections or a serious bacterial infection as well. So that doesn't, it tells you it's most likely an infection. It doesn't really tell you exactly where the infection's coming from. His blood sugar was normal, just normal, and his malaria rapid diagnostic test, because he came from a malarious area, was negative. So we're stuck with a systemic infection with thrombocytopenia, a mild rash related to that, a petechial rash, with no clear localizing features, but it's not malaria, and so still could be a number of other things. So the other investigation we said we'd do is get a urine specimen. And there's several ways to do this. In the past, people used to put on a bag on the over the perineum and try to catch some urine that way. That will only get contaminated urine. That's not a very good way at all. A good way to do it is what's called the clean catch technique. And you can have a baby lying down, and if you stimulate the suprapubic area, then eventually they'll pass urine. So you clean up the perineum and then stimulate the suprapubic area, either by tapping on the suprapubic area or by just swirling with a piece of sterile gauze. Eventually they'll pass urine unless they're very dry, and then you can catch a specimen just as it comes out, a specimen of urine just as it comes out. I think that's a very good way. You'll get a urine specimen within probably about a 70% chance of getting a urine specimen from an infant by doing it this way. The other way to do it, it's described in the Hospital Care for Children book, in the Pocketbook, is a suprapubic aspirate. And that can be that's the ideal way to get a sterile specimen of urine, which is what you want to get. You want to get a urine that's not contaminated by the bacteria on the skin around the perineum. The problem with it is that it takes some skill to do. It's ideally you do need to know that the bladder has urine in it before you do a suprapubic aspirate, and the best way to tell that is is with an ultrasound, and so you can ultrasound the bladder over the suprapubic area and see the bladder clearly distended, and you can go um, in in the midline with a very fine gauge needle, and you almost always can get urine out if the bladder's full. If the bladder's not full, then you may struggle to do it. But there's another reason why it wouldn't be ideal. You shouldn't do this in this particular child. And remember, his platelet count was low, and so you risk, if you're putting a needle in, you risk some bleeding, and that wouldn't be a good thing. Like doing a lumbar puncture wouldn't be a good thing in this child with the platelet count of 35,000. That's much lower than what would be safe. So the best way to do it is the clean catch technique, and it's also a good way to do it in most infants. So that's what I would think would be ideal. This is his urine test, and it showed he's got a mild trace of protein. Again, triangulate the information you've got. That's common in children who've got a febrile illness, having a bit of proteinuria. It's not a lot of proteinuria, it's a little bit. No glucose in the urine. His blood sugar was a bit low, and his blood sugar was 3.9, so you're not going to get glucose in the urine if that's the case. But his nitrates are high, his leukocyte esterase is high, and there was blood in the urine. So nitrates, leukocyte esterase, and blood in the urine, using this type of dipstick testing just at the bedside or in a small laboratory or a bench if you've got it within the ward, will very much help to rule in or rule out a urinary tract infection. If none of those things are positive, it's very unlikely a child's got a urine infection as long as you've taken a nice clean specimen. If you've got positive nitrates, that's the nitrates are produced by bacteria, so it seems likely. Leukocyte esterase is an enzyme produced by white blood cells, and so again, if you've got lots of leukocytes or white blood cells in the urine because of an inflammatory response related to an infection, then you're likely to have positive leukocyte esterase. And blood is also sometimes, when you've got a urinary tract infection, you typically have a little microscopic blood. You can't see it in the urine, but microscopic blood. So blood, leukocyte esterase, and nitrates is typical of a urinary tract infection. And certainly on microscopy, this was sent to the lab, and the red cell count was a bit high, and the leukocyte count was very high, 520 times 10 to the 6 per litre. And in fact, at microscopy, they could see bacteria on the microscopic view of the urine. So in summary, we come up with a diagnosis. Johnny had a high fever with no localising signs, a particular rash related to his thrombocytopenia. His urine examination showed signs of infection, and his blood examination showed signs of mild anemia, high neutrophil count, low platelet count, and lymphopenia, low lymphocytes, all consistent with an acute infection. So I think we've triangulated the history and the examination and the laboratory investigations and come up with a diagnosis that seems likely. Now, the question is, how do we treat the patient? So we've done triage, emergency treatment or prioritization of the patient, taken a history, done an examination, done some investigations, made a diagnosis. He's got the main diagnosis, urinary tract infection, and some sub-diagnoses, so mild anemia and thrombocytopenia. How are we going to treat this child? Well, firstly, we need to treat his urinary tract infection and his systemic infection. And And you can look up the WHO Hospital Care for Children book on page 185, the second edition, and it says for a urinary tract infection or serious systemic serious bacterial infection, then giving ampicillin and gentamicin is the right thing to do. So intravenous ampicillin and gentamicin gives you the doses for those as well. Or if you alternatively, you could use intravenous ceftriaxone, but ampicillin and gentamicin is probably better for most urinary tract infections. You should consider whether this child's got just a bladder infection or whether he's got pyelonephritis or generalized septicemia. And that's really a clinical diagnosis to start with. Firstly, if he's got a generalized septicemia, that would be consistent with his high fever and some signs of circulation impairment. So his prolonged capillary refill, for example, his petechial rash, general being unwell and lethargic, that's consistent with him having generalized septicemia. So some children who've got a bladder infection or a urinary tract infection will get bacteremia, that is bacteria in the blood. We don't know that at the moment, but it might be in another day or two the blood culture comes back positive and tells us that he did have a bacterial infection circulating in the blood. That's more common in children who've got pyelonephritis, which is an infection of the kidney itself. And the way to diagnose that would be to go back and reassess whether he had tenderness, particularly in the loin region, in the just behind the just at the back in the lower abdomen at the back, up near the rib cage, up near the ribs in the loin region, or in the flanks, in his abdominal flanks. That might tell you whether he's got pyelonephritis on one side or both sides, and it might suggest whether he's got likely to have bacteremia, bacteria in the blood, as well as being in the urine. This has some consequence because if a child's got septicemia or pyelonephritis, a kidney infection or bacteria in the blood, then the duration of intravenous antibiotics would be a bit longer, and the type of monitoring that you would do would be a bit longer. And any infant who's got a urinary tract infection is much more at risk of these complications, pyelonephritis or septicemia, than an older child who's got just a bladder infection, for example. You should certainly give antibiotics until the fever subsides for 3 to 5 days and until Johnny's much better, until he's improved, he's feeding well, his temperature's normal, and then you can switch to oral antibiotics such as cotrimoxazole, Bactrim or Septrin. Remember we said that the stages of management are triage, emergency treatment, or prioritization, history, examination, investigations if needed, making a diagnosis, looking for other diagnoses, comorbidities or a differential diagnosis, giving treatment, the basic treatment for the underlying condition and any complications, and supportive care and monitoring. And when we've looked at hospitals around the world, supportive care and monitoring is often not done very well. And so part of that goes back to that triage. If a child's got emergency signs or they're critically unwell, then where they're managed, where the location of care and the sort of thing, the frequency of monitoring, and the other things that they need to help them get over their illness. Supportive care can include things like fluid management, nutrition management, giving oxygen, etc. Giving a blood transfusion if a child was very anemic and required a blood transfusion. All those things are supportive care. They're not treating the infection or the disease the child's got primarily, but they're supporting other organ systems to while the infection or the illness gets better. And then monitoring, as I said, location of monitoring, frequency of monitoring, the types of things that are being monitored. In terms of supportive care for Johnny, well, his temperature is very high, and if a child's got a temperature over 38 degrees, then they're going to be quite uncomfortable, and also their metabolic rate is higher. So they're going to be, their heart and lungs are going to be working much harder. He had a heart rate of 185, which is very high, and that would be consistent with a high fever with a degree of generalized systemic infection. And so you'd want to bring down his fever if you can with some paracetamol. In the book, you look up the book and see how to manage fever in such patients. Then there's fluid management. Well, it's hard with this child. He's looked a bit dry, so he might need some extra fluid. He's got a high fever and he might need some extra fluid. Um, uh, to start with, he might not be drinking anything. And so he might need maintenance or near maintenance fluids. But you also want to maintain his urine output. So when you've got a UTI, then you want to make sure he passes urine. On the other hand, if you give him too much intravenous fluid, he'll become edematous. So I generally start with a half to two-thirds maintenance in such a child and make sure you can encourage regular breastfeeding. After his temperature's down, the antibiotics have taken effect, within 12 hours, he should be ideally breastfeeding. He should be awake enough to breastfeed. In the first 12 hours or so, then he might need extra fluid because of his fever, because he was dry and not feeding well, and his blood sugar was a bit low. Remember, 3.9, not very low, but a bit low, and we want to maintain his urine output. So you might give him more than half maintenance to start with, perhaps maintenance fluid for the first 12 hours, but just come back and reassess him and make sure that you're not giving too much fluid. Otherwise, he'll get edematous. And when he is able to breastfeed, then cut back on the intravenous fluids and just give him the fluid that he needs, a small amount of intravenous fluids, and that keeps the drip open and enables him to have to breastfeeding and antibiotics through the IV cannula. So getting fluid management right requires frequent reassessment, and many children require more fluid to start with and then less fluid later on as they improve. Monitoring. Ideally, you should use a color-coded pediatric monitoring and response chart. I'll show you one of those shortly. But and that can dictate, you can then decide on the frequency of monitoring. It's usually quite frequent, every hour or 2 hours to start with, while he's stabilizes, and then it can be less frequent. 4 to 6 hourly monitoring is okay after a child's much better, but to start with, you should have a bit more intense monitoring when he gets to the ward. And certainly a child like this should be seen by doctors at least twice a day, just in the first couple of days at least, to make sure that things are on track, that he's improving, that he hasn't developed a worsening septicemia, or that the fact that he's probably got pyelonephritis doesn't, means that he is at risk of deteriorating. So we'd want to monitor him carefully to make sure he's not deteriorating. This is the monitoring and response chart. This was actually his chart, and you can see that I've gone through this before, but the monitoring and response chart has three different zones. First of all, there's the normal range, which is with the white boxes or the white lines. It's the normal range for various things. So this chart has the temperature, it has the respiratory rate, it has the oxygen saturation, has the degree of respiratory distress, has the heart rate, has the blood pressure, and the AVPU score, the conscious level, the blood sugar level, and treatments given. So you can include all of these things in it. You can decide on the frequency of monitoring. So you might put hourly to start with, and then put the time in up the top, so time and date, the time in that the monitoring is done, and then later on you might make it every 4 hours. So then each column only needs to be a 4-hour window, for example. But to start with, you do monitoring in this child more frequently because he had a very high fever. He had some signs of septicemia, although he didn't have shock, and you'd be wanting to know that he wasn't deteriorating. And you can see his vital signs. He starts off, well, some things were normal, so his temperature wasn't normal, was it? It was in the very high zone, like above 38 38, and so it's in the amber zone. So it's not um, very dangerous, but it is concerning. It tells you the child's seriously ill. When he started his, and then you can see his temperature comes down within the first 24 hours, and then you can see his respiratory rate was a bit high to start with, 48, I think it was when he first came in, and it came down as his fever came down, and not surprisingly, you can see his oxygen saturation all the time was okay. So again, makes it unlikely that he's got a serious respiratory infection like pneumonia. His his heart rate was very high. In fact, in the danger zone, in the red zone to begin with, 185, and then slowly it came down over the first 24 hours. And his capillary refill time was a bit prolonged to start with, and then it became normal. And his conscious level in an infant, a bit hard to tell, but he only responded to painful stimuli to begin with. Only he didn't respond to verbal stimuli, and then later on he became responsive to verbal stimuli and alert. And you can see written here that he commenced breastfeeding after about 24 hours, so intravenous therapy for the first 24 hours, and then afterwards was able to breastfeed. So this sort of chart tells you about the response of a child to treatment, but it also enables you to detect a deteriorating patient. And so if the vital signs, if the observations were going from the white zone to the amber zone or to the red zone, then you'd be more concerned. And it's called a monitoring and response chart because it demands a response. If a child's deteriorating, their observations are going into the red zone, then they need to be seen by somebody who has extra skills in the management of critically ill patients, and decide whether the location of management is correct, whether anything needs to change. Are we missing something? Is there a diagnosis we haven't yet identified? And what needs to change about his management? Or are things still okay and we'll just carry on with the treatment? They need to be deliberate decisions made by people who have skills in the management of seriously ill children. And as you get more experience in this systematic approach to the management of seriously ill children, you'll get good at it too. Now, we've talked about triage and emergency treatment, taking a history, doing an examination, doing investigations, coming up with a diagnosis and other diagnoses, giving treatment, monitoring and supportive care, and then don't forget discharge planning and follow-up, because when a child comes into hospital, you need to be thinking, well, how long is it likely they're going to need to stay in hospital? Parents will want to know that. And if you don't tell them anything until the day before they're about to be discharged, then parents, they are confused throughout. They don't know how long they need to stay. So you need to sort of think to yourself, well, most likely Johnny will need to stay in somewhere up to a week, but it shouldn't be more than a week. But in that time, a child with a urinary tract infection, even if it's a complicated one with pyelonephritis or with a septicemia, hopefully he'd respond to that, the treatment, and he'd be improved within a week. But then you can tell the parents, well, what milestones or steps need to be improved, what things need to be improved before he's ready for discharge. Certainly his fever needs to resolve. He needs to be feeding well. He can't go home if he's still got a high fever or he's not feeding well. He needs to be alert and interactive, almost back to normal. He needs to have completed sufficient days of intravenous antibiotics. This infection might not get better if you just quickly change him to oral antibiotics. So 3 to 5 days of intravenous antibiotics. If his fever's down within a short period of time, if he responds well, then that should be enough. 5 days should be enough. And then tolerating antibiotics, oral antibiotics, not vomiting anymore, but tolerating to complete 7 days in total at least. If his blood culture comes up positive, so he's got bacteremia, or if he's got signs of pyelonephritis, you might go for 10 days in the treatment, and you might check his urine again. When Johnny came in, he had a platelet count that was very low, and that's commonly associated with infections. So not uncommon that it's linked to a urinary tract infection, or it could be linked to a viral infection. But you'd want to do his full blood count again, maybe at 5 days or a week, to see that his thrombocytopenia, the low platelet count, had resolved. Wouldn't be good to send him home with a platelet count that was even lower or as low as what it was. Usually it resolves when the fever resolves, and it might take a week or more to resolve. Similarly, when he came in, he had a lymphopenia. His lymphocyte count was low. Now, most likely that just reflects an acute infection, but sometimes it reflects something else, like an immune deficiency. Now, Johnny was a previously well baby who'd not had any other infections that we know of and had been well grown. So it's unlikely he's got immune deficiency like HIV or some other thing. But it would be important to just know that the lymphopenia, the low lymphocyte count, had resolved. Got his lymphocytes are back to normal, his platelet count's back to normal. And so I would repeat his full blood count in 5 days or a week's time and make sure that that's got better. And you remember that he had a mild anemia. And so far, we think his diet's been pretty good, but you might want to discuss with the family or advise on appropriate nutrition and complementary feeding as given his mild anemia. So just making sure that from now on, he's 6 months of age, that the complementary feeding he gets is frequent enough, adequate, a balanced diet that he's getting, and it contains enough micronutrients, particularly iron-containing foods, so green leafy vegetables or meat and fish. Now, because Johnny had a urinary tract infection, because he's a young infant, he's 6 months of age, then either during the hospitalization or at follow-up, then ideally he should have an ultrasound, some imaging of his kidneys to make sure that he doesn't have a complicated kidney, an abnormal kidney that's more likely to get infected. And so you can investigate him for a kidney abnormality, which are more common in children who've got UTIs. And that might show what you'd be looking for is whether he's got the part of the kidney is very dilated, if there's some obstruction causing the urine infection, or if you can do an ultrasound while he's acutely unwell in the first few days, you might see evidence of what we call pyelonephritis, the kidney infection itself. We know he's had a urine infection in the bladder, but we want to know, it would be useful to know whether he's got pyelonephritis, a kidney infection, like the bacteria were infecting his kidneys, or whether he's got any underlying kidney problem. This is the sort of thing you see. This is a normal kidney, and it's it looks like a healthy kidney. It's not very swollen. This is the renal cortex, which is the outside of the kidney, and the renal pelvis. And this is a kidney that looks a bit more swollen, doesn't it? There's more black. It's hypoechoic, generally hypoechoic, and just means there's more fluid in the kidney. So there's probably some inflammation. And this is a kidney that's quite widely dilated, and with fluid and urine within it. So the kidney is swollen and widely dilated. These are the sorts of things you'd be looking for in this child. Most likely, he's just got normal kidneys that have got a urine infection and might have had a pyelonephritis. But sometimes you can see obstructed kidneys in young infants or infants who get urinary tract infections. Sometimes you'll see other things like this child has a renal cyst, a kidney cyst that's got infected. So it's useful to do at follow-up, either if you can do an ultrasound, or your radiologist can do an ultrasound, or your ultrasonographer can do one, or if you can teach yourself how to do one, it's not that hard to do. Or if the child needs referral to see a pediatrician to have an ultrasound scan at some stage to make sure the child doesn't have. That's just a follow-up that's needed. The reason to do that is because if a child's got an abnormal kidney, then they're more likely to get a urinary tract infection, and it's important to know that to know that in the first place. to help protect them in the future. So that's all I wanted to say about that. That's really going through going through um, just one cause of fever and systemic illness. So urinary tract infection, pyelonephritis with a systemic illness, a mild a degree of septicemia in an infant, and how we need to, if we follow the WHO hospital care for children stages of management and the standardized guidelines, then you'll be able to treat such a patient. So that's all for now, and I'll post some more of these teaching modules so you can go through and learn for yourself how to use the WHO Hospital Care for Children book in everyday clinical practice. Useful, important for nurses and non-specialist doctors, for doctors in pediatric training, for medical students, for anyone who's looking after seriously ill children at a hospital or district health centre level. So thanks everyone, and take good care of your patients. Right, bye now.